welcome to EM Grand Rounds. I'm Britt Guest.
And I'm Scott Kobner.
We have a great show in line for you guys tonight. We've got some awesome faculty. These are our wonderful, beautiful, amazing faculty. We've got Dr. Whitney Johnson, Mike Weinstock, and Jailyn Avila. Scott, we've got a lot of stuff happening in the MRAP world. There's MRAP Weekly. There's a bunch of conferences we're going to be at. You have a little list. Give us the rundown.
First, we had that competition for the best glamour shot that everyone out there just got to see. Because let's look at those faculty headshots.
Oh, you want to go back to that one more time? Because Whit Johnson wins.
I think she wins by a landslide.
That's the glamour shot right there.
Anyways, as someone who's doing like duck face on my professional photos, you know, for residency and stuff in the mirror.
That's why we just don't have pictures of us ever.
For sure. People see enough of us. We do have a whole bunch in the MRAP universe coming up. So some big announcements. If you followed on the podcast, the mailing list, to hear any of the announcements we've done on Grand Rounds. We just launched MRAP Weekly, which is the biggest change in MRAP, the podcast, in maybe the last 20 years. So check it out. We've got a great free episode, or a segment of an episode, up on the web right now. We hope that you love it. Then we're going to have the opportunity to hang out with some people in person in the next few months. Got actually a lot of opportunities for that. Coming up kind of close, probably running a little short if you're going to buy a flight like right now. But
next week?
Next week, yeah, next week we're going to be in Dallas, Texas at ASAP Accelerate on March 11th. And we're going to be doing that from 7 to 9 p.m. with a little chat. Then we also have an opportunity if you're the urgent care part of our audience or you just want to learn about the Urgent Care Association. We'll be at the UCA in Las Vegas, Nevada. We're going to be speaking on April 14th. And if you want to hop on a flight, like some of us crazy people are going to, from LA to New Orleans, we're going to be speaking also at SEMPA. And the main day that you can find us there will be April 16th. So you got a little bit of wiggle room, you know, do your drinking in Vegas, then, you know, hit up Bourbon Street.
There's some pretty good places to go back to back.
Yeah, absolutely. So Britt, what do we have coming up next for tonight?
We have Images of the Evening, and that's going to be with Dr. Whit Johnson. So let's take a look.
Take it away.
It was all a dream. It was all a dream.
What's up, MRAP Universe? So we are doing clinical images of the evening, and I've got Dr. Jailyn Avila and Dr. Mike Weinstock with me as we tackle some of the images. So let's take a look at our first image, and for this first image, you guys answer the question in the chat, and for our astute faculty, my question for you is, as you look at this image, and mom brings this kid in and she's pretty concerned, what is your disposition here? Are you concerned? What are you doing with this?
I'm a little bit concerned. I mean, that looks painful, number one. So I just feel bad for the kid and the family. But the main thing, I mean, this is like a test question in medical school, right? The main thing is that delayed bleeding that happens sometime afterwards. I'm not remembering exactly the timing, but I remember it's like quite a big range. So I guess the thing that I'm worried about is a significant bleed down the road, even though it seems like it's hemostatic at this point.
Okay. And Mike, what is it exactly that we see here? Just explain to the audience.
So it looks like this kid maybe put his mouth on an electrical cord, possibly.
Right. Exploring the world.
Probably something like that. Unlikely non-accidental trauma in this exact location, but something always to sort of think about a little bit. But I agree with you. I mean, the disposition, especially from some sort of community place or non-children's hospital, is going to be: are we going to send this kid emergently to like a burn center or to a children's hospital? Because to me, it feels like they're not going to really do anything more than what we can do. You can certainly telephone consult if you need to, but my disposition would be to home, but to have then follow up with some sort of wound management or burn center.
Yeah, and that's exactly right. This is the main thing that we want to tell family about. So this is an oral commissure burn. I'm sure that you all got it, and we'll find out in the chat what the concern is that everyone's talking about, which looks like 68% of you got it right and thought that the labial artery bleed is the concerning complication that goes along with this. One thing, as our faculty pointed out, based on the literature, just remember that this type of complication actually has a delayed presentation from it. And actually the bleed comes from the eschar breaking down, and then the bleed happens. And in most cases when this happens, this is 5 to 21 days out. So it is pretty extended from the initial injury. and it actually only happens in 10% of cases. And so I think the big thing here is that, as long as kiddo looks good, they're tolerating PO, they're not having a lot of pain, this does go home, but with the instructions to mom or dad that in the event that there is a bleed, pinch and get kiddo back in here or to a burn center. All right, so let's take a look at our next, oh, sorry. This actually is great anatomy, right? 'Cause that's the thing that we want to target here. So there you go, good job. All right, on to the next one. So my question here for you all is take a look at this image, a couple seconds. Which one of these are you going to IND?
I mean, I'd do the one on the left. It looks like the right ear. The one on the other side, the one with all the earrings in it, the earring holes, that kind of looks like cauliflower ear, and they both happen with auricular hematoma. It's just the chronicity of it. One of them, it's probably a good idea to try drain it in the ER. There's a bunch of different ways to do it. The other one, I would probably refer to ENT to actually fix.
Yeah, I agree. In fact, when you look at these ears, we can just see the picture, but like if you're real world, right, you're going to go and you're going to palpate. The one on the left does look like there's a little bit of a hemorrhage, hematoma, a little bit on the top part there if you look a little bit more closely, looking behind the ear. So really getting into it to figure out, because you don't really want to be INDing a cauliflower ear that's already been, cauliflowered.
Yes, and so big teaching point here is that one of these is acute and the other one is the complication if we don't recognize the auricular hematoma that we see here and actually do the appropriate management on the initial presentation, right? So the cauliflower ear that everyone's talking about comes from not managing an acute auricular hematoma here. And 67% of you guys agree with our faculty that you would also go after that auricular hematoma and IND it. And so the biggest thing I think with doing this procedure is how best we can anesthetize the ear to make sure that we get a good procedure. And Dr. Jess Mason has a great video where we highlight that there's two nerves that we need to hit with this procedure. And so after you load your lidocaine in, the goal would be to almost make a ring block of the ear itself. And so her first poke is going to be headed towards the tragus from the superior aspect in, aspirate, and then you're going to inject on your way out as you see her draw back on that. And then you redirect in the opposite direction towards the mastoid, same thing. Go in with your needle, aspirate first, and then inject on your way out. And then to get the complete block on that ear, you want to do it from the inferior aspect as well. All right, and so our last image of the evening right here, my question for you all is, who's repairing this in the ED?
So I'll take the first on this one, and I would say, not me.
Tell us why, what do you see here?
Well, certainly there's obviously a risk there with drainage of tears, right? And so it seems like ophthalmology is going to need to be consults, and maybe even not just general ophthalmology, but like ocular plastics. But it looks, when I am in there, that maybe there's like actually a part of the skin that's actually not even there anymore. So if you try to repair it and pull things together, maybe that would come together. You could try to push it, I guess. And it's probably not going to hurt anything necessarily to put a couple of stitches in there, but there's no bleeding and there's no rush. So why not go ahead and have that referred to ophthalmology?
I think that this one for me is like pretty important. We're going to need to repair it. And this is like community versus academic. Do you have ophthalmology on call? Will they come see the patient or not? But this is something that does need ophthalmology follow-up hopefully soon, because that eye, if you kind of suture it up as it is, especially with that chunk missing, you could cause some like lasting harm to that entire eye. And side note, please stain that eye. I'm seeing like a little like white kind of thing on the actual like kind of inferior aspect of the iris cornea that I'm a little worried about. Might be an actual like ulcer. So make sure you look at the eye too. But this, I would definitely consult ophthalmology. Hopefully get them quick follow-up. Doesn't need to be in the ER, but within 24 hours I think would be adequate.
Thank you, faculty. I think big take-homes for me here is that there is a lot of literature that says uncomplicated eyelid lacerations totally within our wheelhouse to repair, right? So a very simple, uncomplicated upper eyelid laceration, get a 6-0 or a 7-0 plain gut and take your time when you're doing it. Obviously the tissues are pretty delicate, but we've got some room and some agreement with our ophtho colleagues that those can be repaired by us. Now, anything that involves the inferior margin of the eyelid, anything that involves the medial canthus, like the canalicular system that we're talking about, that needs OR repair with potential stent because we're worried about, the tear ducts and the drainage from there. Anything close to the lacrimal duct, any type of ptosis of the upper eyelid or fat that's protruding from there, you would be some concerned about the levator muscle being involved in that. So those are ones, definitely make sure that you consult, stay away from those, get ophthalmology on board for that. But just know, looking back at that literature, there are some very simple, uncomplicated eyelid lacerations that is totally within our purview to repair. All right, and it looked like 95% of you agreed, I'm not touching that thing. So yes, get ophtho involved. Okay, and that brings us to our mystery image of the evening, which first person to throw the answer into the chat gets Scott Kobner's car, or AirPods, actually. So,
One or the other.
yes. So let's take a look at the mystery image, and I am going to throw down just a little bit of a clinical vignette here. This is a young guy that comes in after a night out, finger is swollen. They can't remember if they got bit by something or hit something, but the finger has pretty big swollen. They can't make a fist. They're having a hard time pain with opening it as well. And you get an ultrasound and you're taking a look. So what do y'all think the diagnosis is here? And I'll actually try to go back a little bit and see if we can run that image again. Can't do it. That's all right. You only got one shot to look at it. So put what you think that the diagnosis is in the chat, and we will follow up with the winner at the end of the segment. So actually that's it for our clinical images. We're gonna go off to our next segment for the evening, which is a new segment called Residence Corner.
All right, everyone. So I'm super excited about this segment. We've never done it before, but a lot of us work clinically with residents or NPs, PAs, and we're asked a lot of questions on shift that sometimes we know the answer to, and sometimes we don't, and we have to look up. So I thought it would be fun to kind of get some of these questions from some of our own residents that have recorded some questions for us, and we discuss them as a faculty. All right, your first question is coming from Ariel, who works with me over at UCLA. All of you.
I have had this happen a lot where a patient comes in, whether it's like a psych, medical clearance, or it's a low-risk chest pain rollout, and all their workup, their labs, their chest x-ray, EKG, all that's negative for anything dangerous. But when it comes time to dispo them, I come and see them, they're tachycardic, and they're not anxious, they're not symptomatic. What would be your approach?
So I really love this question, and I think, like Ariel's already saying, they're not having pain, they're not having fever. We've probably thought of some of the obvious things like that, thought of thyroid issues. I feel like a follow-up question we frequently get with this is, well, how tachycardic is too tachycardic? Is there a magical number? Is 120 too much? Is 150 too much? Do you send anyone out as long as you've done a good workup and documented? So what do you guys think? What's your approach?
Wow, I'm gonna go ahead and just say it. I discharge a lot of tachycardia. I guess it's one of the things where it depends on the situation. Like I'm tachycardic sitting here right now, but
We're all a little tachycardic,
I'm fine, right? And if it's a younger patient, no medical comorbidities, you've done the appropriate workup, and like you said, ruled out all the things. I'm gonna make sure to give them, good return precautions or whatnot. But I am not somebody that has like a threshold number that's like, oh, I absolutely can't send this person out. So.
Yeah, I totally agree with you, Whit. I mean, you think about people come to the emergency department, 83% of them in some studies have an abnormal vital sign, the most common of which is tachycardia. So you're going to encounter this problem a lot. I think it's really important to differentiate the two. A lot of times we say this is unexplained tachycardia, but really what we mean is tachycardia I've been too lazy to explain yet.
Right.
Because there's a lot of, how many times you're going back in the room and being like, okay, so you slammed 3 Red Bulls before seeing me today? Or, one place I work, the area where patients come in and out of is 2 floors away and 270 yards away. And so if you are pretty cardiopulmonary deconditioned, you're gonna be tachycardic. It also really depends what the trend is, if everyone in your triage area is really nervous because they're seeing this ugly mug, I'm not gonna ever use perk because I scared them and they're like 120 when they see this face. So I think there isn't an exact number. It requires a careful consideration. And if you're going to discharge a person, I agree, I do discharge a lot of these people too, because if you ever worked in the a really bustling community shop, have fun with that conversation with a decent hospitalist.
Try to admit that. Like,
yeah.
oh, 110, but I'm not sure why.
Yeah, but I think it's important that there's 3 big categories when you look at the literature of where we make these mistakes with these tachycardic patients. It's in low, like rare presentations of low prevalence illnesses, like the real zebra dissection or something. People who, for some reason, can't readily like give us a reliable history. So they're like have a substance abuse disorder, they're psychotic, or there's another language barrier. And then like the last category, if I remember correctly, is just exacerbation of chronic illness that we're not recognizing how decompensated they are. So, if you get into those 3 categories and there's not a crazy life-threatening thing going on, you can have some reassurance that it isn't like the end of the world, especially if you watch them. That's just what I do though.
I kind of think about this as like a stop point. Like if they are tachycardic, I'm ready to discharge. I will go back and just make sure that I've covered all those bases. And if it's like 110-ish, I usually discharge. If it's higher, sometimes I'll order more tests. But to me, it's just a stop point, and there's no clear cutoff that is universal, I think.
And I think the trend is really important too. Like, were they dehydrated? You gave them fluids, and they went from 150 to 115. I feel a lot better about that. And I think all of us, what this really comes down to is this person safe to be discharged? Are they going to go home and die? Or are they going to go home and eat and drink and be a normal person and then no longer have tachycardia? So I think that brings us to kind of this paper. And Mike, I know that you had some thoughts on this unanticipated death after discharge. And tachycardia was one of the things that really sticks out in this paper.
So David Sklar published this in Annals of Emergency Medicine, and they looked at almost 400,000 patients who died within 7 days. And they looked at patients where there was a possible error with those patients. And they found that tachycardia was present in 71% of those patients. So it's a scary thought, right, that a patient's tachycardic, and maybe that's a marker for bad illness. But it doesn't necessarily mean, just like everyone has said, that we need to do more testing necessarily, but we need to get adequate data. And we need to also consider which diseases which can present with lone tachycardia. So thinking of things, and you can write this in your medical decision-making note, as a diagnosis-specific consideration. So what are those things? Myocarditis can present sometimes just with tachycardia, or maybe even occult sepsis, or aortic dissection like you talked about, pulmonary embolism, maybe there's some sort of substance issues that are going on. So thinking about those considerations, and the other thing would be obviously some sort of arrhythmia too. So thinking about those considerations and making a note and having adequate data as to why you don't think those things are going on, you just need to make sure you have adequate data on which to make your decision and then record that. And if it doesn't sound right to you, and probably broken record, heard me say this in the past, but hard stop your medical decision making. If it doesn't sound right to you, it's certainly not going to sound right to the family or an attorney later on.
I also really love your focus, Mike, on the medical decision-making point, because I think the thing we see a lot, at least I see a lot of my colleagues, and I've been guilty of it myself, it's like, I'll just give like another liter.
Yeah.
You just give some more saline, like all of these kind of things to fix the number, but not the time spent in the thought process of why that number exists.
Right.
And it also doesn't count as a non-tachycardic discharge if you're like watching telly and it's like, 99, all right, discharge.
Right.
That's what we ultimately result to too, of just like not having the bravery to just have the conversation.
Just make that number look good.
For sure, yeah, that doesn't count. Yeah.
All right, I think we could talk about this for days. I want to move on to the next clinical question from another one of the residents that I work with, Missy.
Is there ever a time you would order an ultrasound of the abdomen after a CT of the abdomen and pelvis was already negative?
So I feel like this goes straight to our queen of ultrasound here. And I love this question, the donut of truth. Is it always the donut of truth?
Often. There are a lot of diagnoses that the gold standard is the CT scan, but there are some that actually the CT scan is not the right test for. The one that comes to mind is gallstones. That's a big one. The majority of gallstones are actually radiolucent. You can't see them on a CT scan, but you can see them on an ultrasound, and you can't see cholelithiasis with a CT scan. So gallbladder is one of the main things, but there's other stuff that the CT scan isn't the best test for, including torsion of the ovary or of the testicle, And oftentimes, we might be getting a CT scan early in the patient's course in the ER, and then they have worsening symptoms or develop new symptoms. And I'm definitely doing repeat imaging, often in ultrasound, because it's quicker and at the bedside. But honestly, like I might even re-CT those patients. It's rare, but I might do it. So I have to say, absolutely, if I have a CT scan that doesn't give me an answer, if there is a diagnosis, a possible diagnosis, that ultrasound can diagnose accurately and sometimes more accurately, like gallbladder stuff, then I'm going to do the ultrasound for.
I think this brings up, you kind of mentioned torsion. When I think about ovarian torsion, we have people that come in with right lower quadrant pain, and maybe it's a young female, and we're thinking, is it ovary, is it appendix? What if we go straight to that CT scan and the CT scan's negative? Do we need to follow that up with a ultrasound of the pelvis to really rule out ovarian torsion?
That's a really great question, Britt. I'll take my crack at it. So I think the step back is, what are you most clinically concerned about for the patient to determine the order of any diagnostic tests. There's a lot of great literature specifically about the utility of pelvic ultrasound after a CT abdomen pelvis has been performed. I think there's like 2 or 3 papers on it. And it looks like basically your diagnostic yield of an ultrasound after having a negative CT is pretty garbage. It really doesn't add anything to the care besides a little bit of a weight, just for pelvic ultrasound. But the problem with torsion, like you're saying, is it's really at the heart of it a clinical diagnosis. You have ovaries that are torsing and untorsing. You're only going to get those findings both on ultrasound of diminished flow and edema, or on CT of some of the stranding and edema of the ovary, if there hasn't been a prolonged period of lack of blood flow to that ovary. So if someone's going back and forth and they have the symptoms, everything, I'm getting the CT to make sure it's not an appy, and if it's still unconvincing to me, I might give a call to an OBGYN to discuss the case. But in that case, I don't necessarily think ultrasound is going to make or break my practice for it.
Yeah, I would say that a CT scan and my ovary is asymmetric, perhaps. That type of thing that I catch there, then I would be inclined to kind of run it back on the ultrasound. I feel like a lot of times we lead off with CT, especially again in the community when we're really busy and running and gunning. Maybe you didn't take that good of a history. Maybe your patient wasn't super forthcoming. You just kind of got abdominal pain, right? So you're not necessarily knocked for going CT first, because that might have just been like the vague story that your patient gave you, and then when you put them into a private area or a room, then maybe you found out it was testicular pain instead. So of course, then the appropriate test is going to be an ultrasound in that case. So it's got to one or the other. Either you're taking a really solid history and doing a physical exam that helps kind of guide you in the direction of those things that CT is not good for, that ultrasound is the best test for. Or, if you're firing on CT first, you're doubling back with the reassessment after the fact.
I think to directly maybe summarize what you said and kind of maybe practice the same way, that's kind of cool. When do you order the repeat one? So if you have somebody who has a significant enough history that you're thinking has ovarian torsion, you get the CT and you see a difference, like in an adult patient, important, this is different than peds.
Yeah.
An adult patient, 4 centimeters or larger of that ovary, or any of the other findings, move on to ultrasound if they're still symptomatic.
Yeah, absolutely.
Is that what you do? Okay.
Yeah.
And I think, oh, sorry, go ahead.
I was going to say, I hate to really keep coming back to the history of physical, but the fact is that there was a study by Gauthier that looked at patients with testicular torsion and found that about 31%, so about a third of the time, that presented as just abdominal pain by itself. So if you have abdominal pain, if you have elbow pain, right, you're going to examine the joint proximal and distal. In the same way, if lower abdominal pain, of course you're examining the proximal, the upper abdomen. Who doesn't do that, right? But then extend it to the lower part, because you could have testicular torsion, and I don't think any of us are doing an ultrasound after left lower quadrant pain in a 50-year-old, right? On the other hand, right upper quadrant pain like you're talking about. So it's going to be very dependent on, again, that data that you get from your history and physical, as far as directing what is the question that I'm asking with the CT scan, and did the CT scan adequately answer my question?
And it's rare in the CT notes, you're like, please extend CT abdomen pelvis to end of scrotum. You get the ovaries in the pelvis, but you don't always get when you need to scan the CT.
Yeah. Right.
And I just want to make one more plug for torsion, because I think this is really important. It's actually a diagnosis made in the operating room. To be completely clear, we can be suspicious for it. We can have findings on CT and both on ultrasound. But remember, normal blood flow or blood flow to an ovary doesn't actually rule out ovarian torsion, because there's 2 arteries, dual blood supply. So you can see flow to a torsed artery or to a torsed ovary. All right, so our third question, this is coming from Olivia. Oh, and this is our donut of truth. I just want to turn to this really quick. This is provided by Whitney, and this is just a good summary of what CT scans can be really good for and when ultrasound could actually be superior. Testicular torsion, gallstones like we talked about. All right, so Olivia, let's hear our third and final question.
What is the best management medication-wise of AFib RVR in decompensated CHF patients?
So this is a big question. This is a complicated question. And I want to start by just asking people, I feel like my knee-jerk reaction is like, well, if they have heart failure, we should give DIG. Who gives DIG traditionally, frequently? That's your go-to for heart failure.
Not a go-to, but I've given it.
Yeah. It's not a first line for me. It's when I've kind of like escalating, like if they're on a DILT drip, I'm escalating, not really getting good rate control. I've oftentimes talked to the cardiologist and we've agreed that it is appropriate to DIG load somebody, knowing that ultimately it does take digoxin quite a bit of time to take effect. And not only do you have to do the loading dose, but then there's the subsequent that you have to give to them after. And there's like good dosing strategies in Corpendium. I always have to look it up, but it's not my first go-to, but maybe a second or third line agent.
And I think what you said, Whitney, was really important, the fact that coordinating that with an inpatient person, cardiologist or hospitalist, because by the time it takes effect, maybe that person would be actually in the hospital. If it's AFib with RVR, you're probably admitting that patient, I mean, almost all the time. And so, yeah, I mean, by the time maybe 4 or 6 hours passes, or maybe even shorter than that, but they're going to be under their care, right? So that's probably why we don't give it that often. I'm exactly the same as you guys, right? You know, you're going to give a medicine, and you don't know if it's even working for hours, and the patient might be gone from the ED by that time.
Yeah, I think to answer it was Olivia, it was her question directly. Like for me, the first thing I reach for is time. I think when you see a decompensated heart failure patient and they're in AFib RVR, seeing 130 on the monitor, the person's working to breathe, like for some reason, whether it's because we're all trained to like look for these tachy dysrhythmias, we want to fix that number and we think it's going to magically fix the rest of the problem. But in almost a majority of cases, just made up anecdotal number there, my own Cochrane review there. Like, in most clinical situations, like the tachycardia, the AFib RVR, and the decompensated heart failure patient is a compensatory response. And so like that's the last thing I'm really messing with. I'm going to try to optimize every other part about their cardiac output and allow their body to do physiologically what it needs to perfuse, and then come back to it if I need to later on. And like on the CCU, like after you admit these patients, it's like 2 days that they're like working that heart rate down a lot of the time to like just get them where they need to be.
Yeah.
And I think this question comes from that traditional teaching, right? Like you don't give a beta blocker or a calcium channel blocker to somebody with heart failure. And I think, you know, once, to Scott's point, once you've really assessed all the other things that could be causing the AFib, is it just primary AFib or are they septic? Are they in hemorrhagic shock? Is there something else contributing to this? I think that, you know, it is okay to give a beta blocker or a calcium channel blocker because in the end, what's really going to help this person's perfusion in EF is slowing them down. Now, with that said, if they are at all unstable, obviously we're all shocking them and this person's going to have pacer pads and all of those things. But I think that traditional teaching of like you can't give a calcium channel blocker or a beta blocker to somebody with heart failure isn't necessarily, you know, really how we practice and what we see works clinically.
Yeah, the good point there is it's about being delicate about it, especially because oftentimes it is compensatory. And so when you're thinking about looking at beta blockers, right, like Esmolol, use the short-acting beta blocker. You can use DIL, you're going to do just fine with those, but it's not to press that number back to whatever you think normal is. I always talk with my residents about like, what is that patient's maximum heart rate, right? It's 220 minus the age. Okay, well, you know, if they're in the 120s and they've got room to tack, let them compensate because by trying to blunt their response, their compensatory response, you could actually tip that patient over and then you're running a code. So you do have to be like very diligent and mindful of the fact of, like you were saying, that it's compensatory.
Yeah, these are, I think, probably in the top 10 scariest patients for me, like the truly decompensated heart failure patient, because there's just so many knobs, and even if you're a pro at ultrasound, like it's not like you're truly calculating like, you know, all of these sweet CCU numbers to figure out. I personally can't do that, but even eyeballing EF, like you don't really know which way to go a lot of the time, so it's really being gentle. You can easily tip them in the wrong direction.
Yeah, these people are so fragile, and oftentimes like their blood pressure already lives pretty low, so we just like we have to be very cautious and very careful, I think, about the way that we approach these patients. And also, kind of going back to that first question, it's not about just treating a number, it's about treating the patient. Okay, cool. Thank you guys so much, and thank you, residents, for participating. And if you ever have questions, please send them in to us. We'd love to incorporate residents and learners from all other different programs. So next, we have a kind of fun little segment here. It's called Am I That Attending?
All right, let's talk about what exactly we're doing with this segment. Am I that attending? So we're both big Reddit people, spend a lot of time on the internet, and there's a very great subreddit called Am I That A-Hole? Right, like basically people just like post stories of stuff that happened to them, and they want to know, am I the person that was a jerk, or was it the other person?
Some of the stories are horrifying too. Yeah. So it's like, clearly it's you, bro.
Yeah, totally. And we've been talking a lot. We've obviously talked to a lot of our colleagues. We've gotten some stuff actually written in by people. We spent a lot of time educating about not just the milligrams and the approach to certain things, but it's also important to talk about the culture of medicine a little bit. And I think some of these questions kind of get at that. So get at that rather. So let's dive in to find out if you are that attending or not with some of these questions we've had submitted.
Yes.
Does that sound good?
Trigger warning for those of you that are a little bit brash like me, because you're probably going to be that attending. But if you are, put it in the chat. Don't be afraid. Admit it.
Yeah, we're going to launch quiz results the entire time, and we'll talk about whether or not you guys do some of these things. You ready for the first one, Whit?
Yeah.
All right, so this is a great question. So are you that attending if at change of sign out, or right after you sign out a case, you change the previous physician's orders? So someone was ordered with like a CT or whatever, you come on shift, and you're canceling that order set.
All right.
Is that a jerk move?
So it's probably a jerk move, but I'm going to go ahead and say I am that attending. And it probably really annoys the crap out of residents more than anything. I don't know if you remember, but like going to one attending or working your whole shift with one attending and thinking that you've got like the plan down packed, and then new attending comes over and they're like, no, that's me. I'm that attending. Like, what? No, we're not doing that. So yeah.
Yeah, I totally feel like this is not a jerk move. I think it's funny
It
if
is
like
a jerk move.
I don't think so at all. Here's what I have to say: if you couldn't dispo them in your shift, and it's my job to dispo this patient safely, like my name's on the chart. The point of the sign out is to like have another person take a look at the patient, in my opinion, right? Sometimes it's like follow up on a CT result or something like that. But if it's a true sign out, you haven't finished the clinical impression. And if ultimately I'm in charge of this patient's clinical disposition, their decision making, like. My name's on the chart. I'm going to have a say in what happens. And also, when you look at data, right, at times of sign out, we look at the number of CTs, for instance, emergency physicians order throughout their shift. Towards the end of the shift, there's a big uptrend when you look at the literature. And why is that? We get, cognitively spent. It's a convenient reason to be like, hey, the CT is still pending, if you're at a place that does those kind of sign outs. So I think it's totally reasonable. And in fact, I think necessary, I will argue mandatory, to go into the room, reassess that sign out patient. And if you disagree with the previous plan, like, I'm not going to let somebody else be in the captain's chair while it's my shift,
You smoothed it over by saying, like, go back in and reassess the patient, and then, okay, all right, so you're playing that game.
A little corollary to this one. How about MSE or doc in the box orders? Someone ordered a D-dimer and triage, and now they're in your booth and they're here for ankle pain.
If you are the doc that orders a D-dimer at triage, you can go right. No, I'm just kidding. But I do have that. Like I feel like I'm one of those docs that I'm giving away all my secrets. I will purposely grab up those patients so that the triage orders don't go in, so that I get my assessment, my orders my way, versus having to double back and explain someone else's orders. So I'm that person.
Totally. It looks like in the chat, 60-40 split. I am that attending for changing the orders. I'm not. I will say the other caveat here, kind of the MSE bit, if you can ask that clinician why they ordered that thing, really important. Because sometimes the patient comes in with a totally different presentation. For instance, we were just talking about torsion. That patient could have shown up worst pain of their life. You go to see them, they've untorsed, and it's like you're playing bongo drums on their belly all day. You might be tempted to cancel the test. So for any of those anticipated sign-out issues, I really try to ask why they ordered something if I'm kind of questioning if I should continue that plan. Fair enough?
Fair enough.
All right.
Communicate.
Communicate. Pretty basic, but we mess it up all the time. All right. Am I that attending?
All right, so am I that attending if I sign out a lumbar puncture or any procedure at that?
All
How
right.
do you feel?
Okay, I'm going to lumbar puncture first.
Yeah, okay,
100%
all right.
you're that attending. That's a jerk move to sign out the lumbar puncture. Here's a few reasons. Like, I think, I guess I just trained at a place, even though all the places I work at, I should say, have an amazing sign-out culture. You could probably sign out anything, and everyone's cool with it. I'm happy to receive any sign-outs. I think it's wonderful. If you're working at an RVU shop, it's a different story for a lot of people who are probably listening. Like, you're playing till the buzzer, till all the dispos are done. I think signing out a procedure is just like such a harsh thing to put on somebody, especially at a single coverage shop. Right? If you're the only doc there, and you're like, hey, I'm going to sign out this 88-stitch lac repair, that's awful. The same thing with a lumbar puncture, because I think there are a lot of ways, if we're talking about LP for subarak, you could have avoided that. Maybe it was planning the shift a little bit better. Maybe it was not doing the LP and doing like angio imaging. There's some evidence for that. And I think ultimately, at least how I practice, like if I'm committing the course of care, talk to the patient, we're going to do this procedure, talked it all up, I'm going to be the one that actually does it. Like if you pass the sentence, you swing the sword. And for me, I'm okay staying an hour after my shift. I'm okay signing out the results, like follow up on my champagne tap if I'm so lucky. But I don't think it's cool to sign that out. How about you? How do you practice?
I mean, I feel like it goes back to when it is in the shift. Like I'm going to be totally honest, because sometimes you're, trying to do the right thing for your colleagues in the department by seeing patients, getting things started and getting things moving. And so for me, if it's a late pickup, I'm sorry, dude. I'm going to sign that out. I'm not staying 3 or 4 hours for my own wellness and my own zen. But like if I look at the tracker board and that patient's been there for 8 hours and you come up to me and you want to sign out an LP, I'm going to still take your sign out because we should all be collegial, but we're going to have words.
I'm going to judge you. Yeah, it's the one thing about the EMR is you can be like, oh, you ordered that head CT and the result was back for 4 hours. And but obviously every shift's different and like be flexible, but that's just my practice. Let's see what the chat say. So I'm not that attending, so not a bad move to sign out that LP. 21% might agree with me.
So 21% think it's okay to sign out the procedure?
I think 78% think it is okay to sign out the LP.
Okay.
21% think probably not. Unless they all misinterpreted that and it's flipped. But that's how I feel. So, all right. The final question. This one's amazing. This is a real question. This is a real situation. Am I that attending if I activated the cath lab at my hospital because cardiology wouldn't call me back? Would you ever call a code STEMI, activate the cath lab because you couldn't get a hold of cards? Or any consultant for that reason, activate to a higher level of code, higher level of hospital alert system?
That's a real dick move. I'm just going to say it. This one's kind of crazy. I mean, you're kind of a G. Like, that's real gangster if you do that, but that's horrifying. So I am going to say that you're probably that attending if you've gone the extra mile to activate the cath lab. Because with that, think of the gamut that comes with that, right? Like, you're mounting a full team response. A little bit of an asinine way of trying to get a cardiologist to call you back, but maybe situational? I don't know.
Yeah, I mean, I think the big thing there is that when there's like a sacred bond when you activate like if you work at a place that has like a code PE, if you're activating the cath lab for a code STEMI, if it's a trauma activation, it's because you need those consultants to provide like life-saving immediate care. And the gamut, you're totally right. There might be like a nurse that's driving in from home who's the cath lab IR nurse, right? And like that absolutely sucks if you did that to call that person in. I think, I've worked at a place where this has happened, which is hilarious to talk about, horrific if you're working on that shift. But it goes to a larger point of like disputes with consultants and appropriateness of care. I would never do this in a million years unless I absolutely believed like this patient needed a cardiologist right now and every other option was exhausted.
And that's the point, right? It's a matter of like, I'm just doing it to be a dill hole, or like this is an escalating move in a patient that I'm actually concerned about. And I'm giving you the courtesy of trying to call you multiple times, but if it's between that and making sure I'm doing the right thing for the patient, then I might go ham. Like, but this is like nuclear.
This is a nuclear option. And like, if you're wrong on this, like, oh, that's a horrific.
That's the other thing. If you're gonna swing, you have to hit, right? Like you can't pull this off like a G if you're just absolutely inappropriate and wrong, and you're just trying to ask about medications. Like,
so for argument's sake, I think the one part, like not just interpreting this as like the person, the cardiologist was playing golf, didn't call me back for 4 hours. If you work at a place where you don't have a great departmental relationship with cardiology and you're kind of OMI criteria are a little bit lacking, just like occlusive MI. You're not, sometimes we call them in this evolving landscape, STEMI equivalents, or, you know, like the people that have hyperacute T is a great story.
Right. Dynamic EKG.
Yeah, and like, because a lot of places now, people will just try to call cardiology for that, have a quick discussion, review the ECG. I could see there being an argument for that if you feel strongly enough, like just activate the cath lab. But I think that more speaks to you believe they have an intervenable lesion that you need a cardiologist for, not like, hey, like the back nine sounds great, but get in the hospital.
Right.
I need you to help me with LASIK or whatever you're calling them for. Let's see what the audience said. All right, so broken down here. Oh, okay, so 42% said, I am not attending. Wow.
There's so many gangsters out there.
Yeah.
That's so brave.
That's-
I imagine that is situational. I'm going to just say that.
Yeah, it's hard. Obviously, we presented this question as kind of like, there's a lot of room in there. We have an upcoming segment on MRAP actually on conflict resolution, which kind of goes into some of these issues too, which is nice. You know, we're always in the ring with our consultants.
Yes.
Sometimes we don't like to be, but
I like
yeah.
that. That's a
I
really
like
good
to.
segment. I'm really hoping that more of you guys continue to write in, give us your stories. We'll maybe try to revisit the Am I That attending, but it'd be great to have more from our viewers.
yeah, I want to know, you know, that sign out, supposed to pick up patients for the last hour and 5 minutes. Like, where do we draw that line?
There's
you know,
some questionable ones
yeah,
out
that
there for sure
complicated,
that
you know,
are epic.
A little bit more of the culture of medicine. Well, that was our Am I That Attending segment. We're going to throw it back to you in the studio for our procedure of the week. I think we're getting a little lathered up. We're getting a little jelly in here.
It's
Yeah,
time.
some ultrasound.
greatness.
This month, what we're going to talk about is an ultrasound-guided pericardiocentesis. Now, for this procedure, hopefully you've already adequately diagnosed that tamponade on your ultrasound. And if you need a little review on that, just check out the Corpendium chapter on it, check out the YouTube, the MRAP YouTube for it. And let's say you've diagnosed it, you're the person that needs to do a procedure to drain that and potentially save that patient's life. You're gonna need a couple things. The first one is, of course, your trusty ultrasound machine. You're gonna also need the equipment to actually drain that effusion. Now, if you are able to get a pericardiocentesis kit, you have access to it, please go for that. It's made for this procedure, but if you don't have access to that, you can use anything that has a stabby end and a suction end, right? So you can use a central line kit, which I actually would recommend if you don't have a pericardiocentesis kit. And you can actually leave the triple lumen in there, but you can also just use a spinal needle or an angiocath. And once you do that, you get that ready to go, you are ready to perform that procedure. You can definitely do this landmark, but you probably will be more accurate, less likely to cause complications if you use your ultrasound to help you. Now, we're going to talk about the different views to figure out what is the best pocket, and it really is patient dependent. Some patients are going to have the best pocket in their peristernal window. Some of them are going to have it apical. Some of them are going to have it subcostal. Let me show you where you place a transducer for your peristernal window. So you place the transducer just to the left side of the patient's sternum with the probe marker facing to the patient's right shoulder, right about here. Now, with the procedure, you're often going to come with the needle just on this side down into that pericardium. And what's interesting is that while you do want to use your phased array transducer to diagnose that effusion, you shouldn't use it as your preference for actually performing the pericardiocentesis. And here's why. The phased array transducer is a lower frequency transducer, which means the image quality isn't as good. To get a better image quality, you should switch over to your linear or your curvilinear transducer. Really, all you need is you need to be able to see the subcutaneous tissue, the muscle, the fluid, and just the most superficial border of the heart. That's really all you need to see. This is an image or a clip of what you can get when you look with a linear transducer in the peristernal window. We can see here the needle entering into that pericardial fluid. We actually are able to see the guide wire float in. And this is, to me, a phenomenal view to get that accurate pericardial centesis. The next view I'm going to talk about is the apical 4-chamber view. You're going to want to use your pencil grip with a probe marker going to the patient's left side. Place it right about here in the inframammary fold. Usually to diagnose tamponade, to get a good view of the heart, you want to have your transducer just a little lateral to make sure you're right at that point of maximal impulse to get that perfect window for the heart. Now, when you're diagnosing a pericardial effusion, yes, you need to see the heart, you need to see the fluid, but you want to identify the pocket as the thing that you care about the most, so you want to bring your transducer a little more medial, which is why on this image right here, we are seeing the liver in view because we're a bit more medial than the traditional apical 4-chamber view. If you notice the shape of the wedge, I'm using a curvilinear transducer here with a higher frequency. Now you can see here, I have the pericardial fluid in the center. The heart's off to the side, the liver's off to the side there, and I'm aiming for that fluid in the middle of my transducer, and you can see that hyperechoic tip of that needle in that hypoechoic pericardial effusion. Now I'm looking at this now, and honestly, there's a thing that it worked. We were able to get fluid out of this pericardium and help the patient's obstructive shock, but I would have decreased the depth a bit. We don't need to see the whole heart to do a pericardiocentesis. Like I said, we just need the fluid, and then we need to be able to see the most anterior or superficial border of the heart in that window to get you the best resolution image. Let me show you now the same view. It's an apical 4-chamber view on a different patient where we decrease the depth, still using that curvilinear transducer, and you can see here that we're able to see a lot more clearly that pericardial effusion and that hyperechoic dot of that needle. Now, if we look at this, right, I mean, we're seeing this hyperechoic dot. I'm looking at this and my first kind of inclination is I would much rather see this in a long axis, the needle itself, just the whole needle. But here's the thing, with anything through the rib cage itself, you don't have a whole lot of space. So you're very rarely going to get that perfect view of that needle and the perfect view of the effusion. So you're often having to do a bit of a hybrid approach, maybe an oblique approach with that needle, maybe a short axis approach rather than a long axis approach, because that's the only way that you can actually get into that fluid. Another important consideration is the fact that if you're in the chest wall when you're doing this, you got to be careful about blood vessels that might be in the area. You got to be careful with those infracostal, those rib arteries. I'm blanking on the word, the rib arteries. The rib arteries, be very careful with those. You don't want to stab into those because that can create tamponade in of itself. And then, especially in the peristernal window, you want to look out for that internal thoracic artery, also known as the internal mammary artery. And you can identify those by placing color flow Doppler in the region in which you are going to perform that before you do the procedure. If you see color flow going through a blood vessel, maybe pick a slightly different area. And thank you to Eyelid EM for their website and giving us this amazing picture of the internal mammary artery. Now, the last view I want to talk about is the subcostal window. With the subcostal window, we're going to do a different grip. So we did a pencil grip for the first two, the peristernal long and the apical 4. We're going to do an overhand grip with a subcostal window. We want the probe marker facing to the patient's left. We're going to place it right here in the subcostal window, right underneath the xiphoid. And we have to kind of push down a bit. We want to get the beam underneath that xiphoid process, kind of like we're trying to scoop out the xiphoid. You want to push it down and be able to get to the heart, which is sitting over here. Here is an image of an actual pericardial effusion, a quite large one that is causing pericardial tamponade. This is, apart from vital signs, this is a heart that looks very much in distress. I'm using the phased array transducer here, and this is a completely adequate and good view demonstrating the pathology that you're trying to fix. But if I want to be really accurate with my needle, I'm going to change my transducer to either the phased array or the linear transducer. And in the next image, I'm going to show you the same patient, but the curvilinear transducer with the depth very shallow, right? We're only seeing the effusion and the most superficial border of that heart. And we can see here that we're able to see that needle entering that pericardium a lot more accurately than if we had the phased array transducer and very deep. Gives us a better image, which is what we want. Now, I have to mention, in the subxiphoid window or the subcostal window, we run into issues because there's not a lot of space. It's almost impossible to stick a curvilinear transducer there and the needle in that tiny subcostal window. So what you're going to have to do here is an out-of-plane technique, and it's so out of plane that I like to call it the whoop technique. That's the way out of plane technique. And you're using your ultrasound to basically identify where that is, find that effusion, and your needle is going to come directly, almost in line, in the short axis, just into that pericardial fluid, which hopefully you're going to get a view of that needle tip at some point. But if you just are aiming it, you know that if you go straight in, you're going to hit that fluid. That, to me, is adequate and how you often need to do it when you're using the subcostal window for your pericardiocentesis. This is such an amazing and important procedure and will so much benefit your patients. I mean, this is something that is a quick procedure that is so life-saving. You don't want to cause complications here. And before you actually can thread that catheter, and this is any of the locations that you do it in, you can actually do confirmatory testing to even lower that risk of that complication even further by doing a flush test. So the way that you do this is you will get a little bit of blood back just with your introducer needle, and then under ultrasound visualization, you will push that blood that you just aspirated, maybe 2 to 4 cc's, you're going to push it back in, and you're going to look with ultrasound to see if you see agitation of that blood that you just pushed back in there. And if you see a bunch of bubbles, a bunch of fluid all in the inside of that pericardium and not in the heart itself, not in the ventricles, you are good to slide in that guide wire, dilate, and put in that catheter. That's how you do an ultrasound-guided pericardiocentesis. Next, let's check with Scott and see how the chat is doing.
Thanks so much. That was awesome saying, wishing that you had ultrasound in that moment, especially that really sleek, perfectly set up one for someone who is crashing in front of you from tamponade. It definitely makes a very stressful situation a lot less stressful. Done a few of these so far in my career. I've seen some done totally blind, and let me tell you, the blind approach, for all of you who have been practicing long enough to like actually have to do that and maybe have like an old CRT monitor that you're hitting the side of to get that image to load up, that's a pretty brave move. Pretty impressive that that's what we had before. Thanks for sharing that with us. I thought we'd check in. There's a few questions that have been in the chat. It'd be a nice time to just update you guys along the way. The first question was part of our residents' question corner, and it was about decompensated heart failure patients. Shouldn't that patient just go straight to cardioversion? I really love talking about what it means to be decompensated when somebody has a tachydysrhythmia, because if you look at every single textbook, every single ACLS, whatever guideline, you're going to get some different answer. There's hard cutoffs at systolic less than 90. Well, that doesn't really make sense if this person has like a 2% EF and their midodrine assisted baseline systolic blood pressure is 85 on the best day ever, right? The decompensation line is super, super vague, and it's really about multiple clinical observations and your understanding of the shock state of the patient. I'm not going to pretend that I'm an expert in explaining shock. I highly encourage you to check out a bunch of Sarah Krager's work on our website, some of our HD video series, where she goes into different types of shock and her whole mental process, thinking through it. But in reality, the big takeaway for these patients here is like, really think about what's causing the decompensation of this patient. If they have a low blood pressure and somewhat altered mental status, but the AFib with RVR is compensatory, just going ahead and cardioverting that person might not actually improve what's happening to them. You still have to reduce their preload, augment their afterload, all of those really important things. So know that there is a big gray area here, and it's impossible to tell you in a small 3-minute answer to this question what needs to be done, but serial observations and really thinking critically about what's driving this patient's decompensation is kind of the gold standard there. We had another great question. When you're like looking at abdominal pain, when you're ordering diagnostic tests, what about non-contrast CTs? And if you practice in the United States, you know there was the great contrast shortage maybe like a year or so ago, and regardless of what your department's policy was, what your radiologist at your institution preferred, many places you just couldn't get contrast. And all of a sudden, we learned that a lot of the things we get contrast studies for probably don't need contrast in select patient populations. So the big takeaway points here are people that you're looking for vascular emergencies in, you know, that need an arterial phase imaging, that you're worried about leaking blood vessels somewhere in their abdomen, contrast is always going to be your friend there. And when you're kind of picking apart Hounsfield units, it's way easier to figure out what's blood and what's not if contrast is infused in that leaky vessel or to highlight that dissection. For people who are larger body habitus, actually the attenuation of X-rays when you perform a CT is actually pretty great, and the mesenteric fat moves apart the organs enough that you can get great visualization of all of your hollow structures that most studies looking at non-contrast CTs to look for things like appendicitis show similar sensitivity specificity. So you don't always need to get that contrast study, which is great. And if your institution has a protocol for that and your radiologists are okay reading that type of study, that's wonderful too. I think it really comes down to having that conversation with the person who's going to be reading the study and thinking about what you're most worried about. I know we have some more questions in the chat. People are going to be pouring them in. We'll be answering, slide into our MDs that are out there. But right now, we're going to go back to the studio for our last segment of the night, Bouncebacks.
Hold on, and this.
Tonight I want to tell you a story. It's a story about a 5-year-old boy with vomiting, a story we've heard many times before, but this story ends a little bit differently because if one thing had been recognized during the evaluation, this patient's life could have been saved. Now, before I tell you the medical encounter, I want to back up just a little bit and tell you about Jordan. He's a 5-year-old boy. He lived with his mother in South Carolina, a busy public defender, and while she was working on a high-profile case, he was being watched by his grandmother, a custodian from New York City who had a 6th grade education. They woke up, she gave the patient eggs and cheese and orange juice, and about 30 minutes later he started vomiting. So she decided to take him to the emergency department. And here's the history of present illness. 5-year-old male with 3 episodes of non-bilious, non-bloody emesis over the last 2 hours, starting half an hour after eating eggs, cheese, and toast and orange juice. He denied any abdominal pain. Had a past surgical history of an appendectomy, and here's his vital signs. Not really too bad. Heart rate probably a little bit high, maybe even respiratory rate also. His physical exam showed him to be alert, well-developed, tired but non-toxic, mild diffuse discomfort of palpation, so a little bit different than what we got in the history. Well-healed midline scar, no rigidity, rebound, or guarding, and his GU exam was deferred. The patient was diagnosed with gastroenteritis and discharged with a prescription for Phenergan. So I want to start off by asking all of you folks who have obviously so much expertise, and Whit, I don't like how you said that. Did I build this up too much? I'm sorry about that.
You're that.
I'm not attending.
All right, so the history is different than the exam. He denied abdominal pain, but on your exam, you got abdominal pain. Which do you believe, and where do you go from here?
So I think the biggest thing for me here is that one of these is subjective, right? So pain for our patients, when they're talking about it, that's subjective. But I trust my hands and I trust my exam. So eliciting tenderness is something that to me is fairly objective and probably more remarkable, especially in consideration of the fact that this is a pediatric patient. Maybe they're a little scared of me. Everyone's scared of me. My own mother's scared of me. But maybe they're, a little bit shy and they don't really want to say that they're having pain. So I wouldn't necessarily trust that the kiddo is not having any pain at this point. I would trust the fact that on my exam, I'm getting tenderness there, and that would give me at least a little bit of pause or want to venture a little further with that.
Yeah, it's sort of funny. We can call these sort of positive and negative kind of questions. Like, is this the worst headache of your life? Or I bet you've had bad headaches like this in the past, right? You can sometimes get a patient to say what you want based on how you ask the question. So our second of the 4 real main teaching points here is the patient had gastro, but not really the enteritis. He had vomiting but no diarrhea. So Britt, there's a specific differential for 5-year-olds who have lone vomiting with no diarrhea.
Yeah, it's a really big differential. And I will say, the vast majority of these kids, maybe he's going to have diarrhea in 2 hours, and he just hasn't gotten the diarrhea part yet. I mean, that's totally possible. And the vast majority of these kids, when you send them home, are going to do just fine. I think you know, we know this is a bounce back case, so I'm sure something terrible is about to happen. But if I think about my differential for vomiting outside of the gastro kind of things, definitely think about, is this new onset diabetes and the kid's in DKA? Is there maybe something intracranial going on? Was there non-accidental trauma? Is there a space-occupying lesion? You know, he's staying with grandma. Grandma may have medications that she takes. Did kid get into grandma's pills and ingest any medications? Think about infections outside of the abdomen too. I mean, a lot of kids with pneumonia will present with vomiting. UTIs, they could present with vomiting. I mean, the differential is really huge here, but those are some of the outside of the box things that I need to start thinking about when I just have a tachycardia and vomiting kid that hasn't really given me that enteritis part yet.
And the really amazing part about this is so much of that suspicion can be heightened by our data gathering, right? By getting a history, polyuria, polydipsia, polyphagia, or maybe even, you know, unilateral numbness or weakness or unintentional weight loss, or in the right setting, something like carbon monoxide toxicity could cause vomiting, and maybe asking the grandmother who thought this was food poisoning, well, does she have similar symptoms? Maybe she also has vomiting or a headache with that. I thought something curious, Scott, that is said under the GU exam that was deferred. And I'm thinking like, you know, what is it, like privacy issues in a 5-year-old? I mean, this is part of our evaluation. It's curious that they wrote it, and it's curious that they did it.
Yeah, I mean, I think this dovetails very nicely from our discussion in the residence corner, where we're saying, you know, doing the, I think you used the euphemism, the joint above and the joint below. You know, this is a kid that has abdominal pain, and, you know, even at that developmental age, even though you're very communicative, might not be able to communicate that there's pain in like the testicles. And I think it's important that you do that exam. You have no idea if this is torsion. You have no idea what else is going on down there, and it's for completeness. I mean, I appreciate the honesty of the person who wrote that note that said they deferred it, because that's just the right way to practice medicine. But definitely in this case, you should take a look. I think it also brings up the interesting question of, we spend a lot of time talking about like what to look for, but a lot of times you don't really focus on what's okay to ignore, because you have to ignore some things in medicine, right? Like we can't chase everything down. In this case, the GU exam, definitely not okay to ignore. But I also don't know if it might have been my first go-to either if I had legitimate tenderness on my abdominal exam, you know, and there's like a peritonitis or something there. I can also see that argument.
Yeah, and you know, you could think that testicular torsion certainly could cause vomiting in a patient without diarrhea. So doing that exam, I mean, could be a very easy answer just by looking. So, Jailyn, we have now come to our sort of question here. Like, is there a game-changing question? Was there a game-changing finding that, if suspected, could have changed the outcome of this patient?
I mean, the big thing when I'm looking at this case is it's not normal for me to see a midline surgical scar in a 5-year-old. That is something that I would definitely want to address, and seeing that in someone that has any GI symptoms, especially a 5-year-old, I am a little worried about something that is atypical in a 5-year-old with a virgin abdomen, which is, you know, something like bowel obstruction, which I think if you had the same patient and they were 65 with a midline scar and had the same symptoms, that would be one of the first things on your differential. So it's a disease entity that we don't maybe see in that patient population. I would like to believe that seeing that scar, I, you know, might have thought, well, could there be something else scary that is very atypical for a 5-year-old to have, like ischemia, like a bowel obstruction or something like that. So that's like the one thing that I'm just, I don't know, it doesn't feel good that doesn't seem like it's been addressed all that great.
Yeah, especially because it's midline, right? So
I was just thinking that.
Most appies, if they're uncomplicated, you've got the tiny little, you know, lap scars there, but you're talking about like an X-lap looking surgical incision, a little questionable.
Totally, like if you didn't know it was for an appy, or maybe there was a health literacy thing, you're not sure, like umphalicele, if there was a previous history of malrotation, to have that massive abdominal surgery at that age, it's totally, I didn't even think about that specific scar being kind of a red flag. Yeah.
Yeah, well, there's sometimes findings that prompt us to go back to the history again, like, for example, the abdominal pain that we talked about. And there's sometimes findings, like this midline surgical scar, that would cause us to want to ask further questions or obtain different data. And, you know, we're the historian, right? The 5-year-old is not a historian, right? The grandmother who's visiting from New York City is probably not a historian. If they had gone back and looked, they would have found out that several months previous, the patient had appendicitis, and it did say past surgical history, API, but it was not just appendicitis, it was a ruptured appendix that required a open repair. So I'll tell you what happened with this patient. Was discharged from the ED at about 1:30, heart rate was not rechecked, abdomen was not rechecked, and went home with the grandmother. They prescribed Phenergan, sort of a sedating antiemetic, and the patient was sort of tired through the day. He was put to bed sometime around 8 o'clock at night, and when the mother came home, she talked to the grandmother, and at 11:55 p.m. went in to check on the patient. The patient had some green emesis on the pillow, unfortunately wasn't able to be aroused. They called the paramedics, who documented a weak thready pulse. They said the child felt warm. They transported and were not able to start an IV line, but did start an IO line, started fluids, but unfortunately on the way, the patient did arrest. And when they got to the Children's Hospital, they had a prolonged attempt at resuscitation, unfortunately unsuccessful. And so the autopsy the next day that was done showed exactly, Jailyn, what you said. This was a small bowel obstruction caused by intra-abdominal adhesions with perforation and sepsis. So what are the lessons we can get from this case? First of all, this was a tough case, and I don't know that I would have necessarily got this either, but there were some things that we could have done to improve patient safety. Recognizing that the patient actually did have abdominal pain, that it was at higher risk because of this previous appendectomy, maybe rechecking the heart rate, and if it was 160 or 170, obviously more concerned. And then finally, making sure that when the patient went home, if they weren't improving, that they understood there was some diagnostic uncertainty and would need to return.
That's a really rough case. Thank you for sharing. I think that's always, it's really important. I think especially in pediatric patients, like, you got to take it with a grain of salt what they're telling you, because they probably don't want to be there. So if they say no pain, there's be no needles and no doctors. And then also, I think just huge point of undressing our patients, examining our patients fully, and recognizing that midline scar, like you said, huge clue in for something probably not so great going on.
Totally, and I think like the other big learning point for me in an age where we're doing more and more imaging, like the importance of the physical exam. So setting your cut point for what tenderness means, like for me in my exam from like the years that I've practiced, like if there's true tenderness, there needs to be some imaging. Like I have, you've developed a sense of like what does a gastroenteritis belly feel like compared to someone that is actually tender as an objective finding. And something you can do on every single shift is follow up on, correlate your exam to every single CT you get and see what your negative CT rate is to like help you differentiate if you're having trouble with that. Is this actually tenderness or not? The author or the person in that case might have truly not felt that that was like tenderness to the degree it needed imaging, and it's kind of about figuring out your set point. No amount of like observation with a mentor or talking about it on a video or podcast is going to help you develop that skill.
And I mean, how many times have we gone to palpate a kid's stomach and they're just screaming because we walked in the room? Sure. And it's like, I can't touch this kid on his toe without him screaming, let alone get a good abdominal exam. Personally, what I've found helpful in those scenarios is I step back and I actually have mom just palpate the abdomen. They're calm, they're cool, they're fine with mom touching the stomach, and they might guard, they might kind of start to cry in one particular place. I feel like I can get a much better abdominal exam that way, especially in young kids where it's just like, you're trying to put the pull socks on and they're screaming their head off. Like, there's no way you can get a reasonable exam on this child.
Yeah, this is a super scary case, and in the end, this was a terrible outcome. Could this have been avoided? Maybe. There was an opportunity to move from standard of care to excellence in care with some of the things that we all discussed. If it would have made the diagnosis, hopefully. If it could have been found, hopefully. And we're always cautious with kids as far as radiation. However, if the patient's presentation was different, this is a 5-year-old with lone vomiting, abdominal pain, who just had an open appendectomy 2 months ago. If it was presented that way, probably all of us would have got the diagnosis immediately.
Mm-hmm.
All right, well, to kind of shift the energy over in the room, let's turn to that mystery image that Whit presented. Whit, what was the answer? What was that? What were we looking at?
Yes, who got it? Who got it? Okay, so once again, this was a young guy that came in with diffuse swelling across a finger. Wasn't sure if he got bit, wasn't sure if he struck it, but he can't fully extend. He's having a hard time making a fist. And Dr. Jailyn Avila actually put this finger into a water bath, and as you'll notice, the tendon, bright, streaky, right, hyperechoic look, but then you'll notice some fluid that's collecting both above and actually, if you watched it real, below that area. So that dark black strip, that's actually fluid. And so Dr. Avila was actually able to diagnose FTS in this patient. This is a flexor tendinosynovitis.
Amazing. And Ashley Wanzer, you got the answer correct. You were the first one. So AirPods or Scott Kobner's car. I'm not quite sure.
Take the AirPods.
He has a van, so I don't know.
We've all seen his car. Take the AirPods.
Ashley, if you could email events@mrap.org, we will send you your prize. It will not be the car. Scott already addressed a lot of the questions in the chat. Thank you guys so much for being active. Thanks to our MRAP faculty for being in the chat, answering a ton of those questions. And UC Max Grand Rounds is our next Grand Rounds, April 3rd. So come and check it out. We'll see you in a month. And huge shout out to all the faculty in studio and the amazing production team that we have that makes every show each month possible. Thanks, guys.